17 years old male. The road traffic accident was the mechanism of injury. Clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a Galeazzi fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex femoral fracture and dislocation, which we called the Galeazzi fracture and dislocation. And this is the X-ray of the femur, the shaft femur, the mid-third fracture of a 17-year-old gentleman, and the forearm Galeazzi fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Galeazzi fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture, and the slight distraction, the tense nailing for Galeazzi fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Galeazzi fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the shaft femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the Galeazzi fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is a 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Galeazzi fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months. But this was not hypertrophic, and this is 11 months. You can see, so after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Galeazzi fracture and femur is minimally invasive, and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Galeazzi fracture in adult after further studies, because I think this is the first case in severe Galeazzi fracture I did TENS. So this case was published in International Journal of Orthopedic Sciences as